Hi, good afternoon, everyone. I'm Chuck Friedman, and I'm happy to welcome you to today's Learning Health System Collaboratory seminar series session that will be focused on network-based research. Thank you for joining us. We are going to have an excellent presentation today. I want to remind you of some things that, first of all, this session is being recorded. The link for the recording, when it is ready, will be shared with all attendees and registrants. The session's live and closed caption. If you have questions, we will have several Q&A intervals during the session today. Please post them in the Q&A pod anytime during the session. And when we do have Q&A at the very end of the session, after both presentations have taken place, you will be able to unmute yourself to ask questions live instead of us reading them from the Q&A pod. So let me, before we launch into today's session, say a few things about events that are upcoming in the Collaboratory's 21-22 program. Our next seminar will be on the 19th of April, and it's going to focus on medical AI. We're very fortunate to have Alan Cartha, I have really trouble with this name, Cartha-Kiesellingham, from Google Health UK, their research lead, to be presenting first, and then we will have a follow-up presentation from Xiao Lu from Birmingham in the UK, and this promises to be an excellent presentation with an international flair to it. In June, recognizing that we are now reuniting the LHS activities which occurred over the past few years with the activities of the Collaboratory. In June, on the 7th and 21st, with the times and exact events and speakers to be announced, we're going to have these sessions in June as the month of LC, the month of emphasis on ethical, legal, and social issues in learning health systems. This will be organized by Jody Platt, and I promise you that these will be excellent sessions. So just keep an eye out for announcements about these. Coming up in May on the 10th, we are giving again an opportunity to partake in the Learning Health Systems Overview Workshop, which we're calling LHS 101. This is a 3-hour session that will take place on May 10th. And then as a kind of companion to this, because there is so much emphasis and importance of learning communities in successful learning health systems, we are also going to repeat from last year the workshop focused on operationalizing a learning community. And this workshop, again for 3 hours, will take place on the 14th of June. Now, moving into our presentations for today, focused on network-based research. We're very fortunate to have both Kathleen McTighe from the University of Pittsburgh and our own Dave Williams as presenters who will be addressing from different perspectives this aspect of network-based research, which is truly gaining in importance and is very fundamental as infrastructure for learning health systems at scale. So let me introduce them in a little more detail. First, Kathleen McTighe, who joined the University of Pittsburgh faculty in 2002. She's an associate professor of medicine and epidemiology and associate director of the International Scholars Program. She's trained in internal medicine, preventive medicine, and public health, has joint appointments in medicine, epidemiology, and clinical translational science at Pittsburgh. Her research interests are in the prevention of chronic disease with focus on obesity, women's health, and information technology. Her work on improving the quality of patient care research extends to a focus on the development of infrastructure for supporting pragmatic, patient-centered clinical research, and this is what we're going to focus on today, via the PATH Clinical Data Research Network, which in turn is a member of the National Patient-Centered Clinical Research Network, or Procornet. Dave Williams is a professor of anesthesiology, medicine, psychiatry, and psychology at the University of Michigan, where he serves as also associate director of the Chronic Pain and Fatigue Research Center, co-director of research and development within the Michigan Institute for Clinical and Health Research, and as a senior faculty member within the Institute of Healthcare Policy and Innovation here at Michigan, also known as IHPI. Prior to coming to Michigan, Dave held faculty appointments both at Duke and Georgetown University Medical Centers. He's both a clinician and researcher with publications in areas of chronic illness management, E&M health services delivery, patient-reported outcomes, instrument development and validation, and mechanisms of pain perception and modulation. Now, on top of all that, and most pertinent to today's session, Dave directs MISHAR's network-based research unit, which we will be hearing about in more detail as we delve into this topic of network-based research. So Kathleen and Dave, thank you so much for being here today. And Kathleen, I believe your presentation will be first. Over to you.
Thank you so much, Chuck. And I really appreciate the opportunity to come and speak here today. As you know, the PCORI Board of Governors has identified learning health systems as being an increasingly important priority for Procornet. And the University of Michigan is already an important partner in Procornet. So I'm hoping that this new mission that's coming to us from the PCORI Board of Governors will actually open some more opportunities for research between our teams. So let me see if I can get my slides to come up. Okay. And let me just check, did that come up okay?
Yes.
Yes.
Okay, great. All right, so today I'm going to be talking about Procornet and the PATH subnetwork within Procornet and how these resources can be leveraged for clinical research. So I'm going to start with a little bit about Procornet. What is Procornet? So if you think about it at the broadest level, Procornet can be thought of as a network of networks, and the goal is really to harness the power of partnership. There are 8 clinical research networks, there are patient partners, there are coordinating centers, actually 3 different coordinating centers make up the overall coordinating center, and overall it makes up Procornet, the National Patient-Centered Clinical Research Network. How did this come about? Well, quite a while ago, Procornet was formed in 2014, so we've been busy for a few years now. And the bottom line is that PCORI saw room for improvement in clinical research. They said, research is often not focusing on the questions that matter the most to clinicians and patients, that research is too expensive, takes too long, we need faster, more efficient research. And so they created Procornet to try to do this. It's a network of networks. It can provide curated EHR data from a lot of patients, about 66 million patients across the whole country. About 30 million of them could be potentially reached for participation in clinical trials. It can provide access to exceptional research teams with expertise integrating research and care, streamline processes to try to reduce some of the administrative red tape involved in doing research, and perhaps more importantly than most other networks out there is an explicit focus on being patient partnered, saying that the patient perspective is important if you really want to include patient care. So why does this work? The sort of official statement on this slide, but I believe it's actually true, is because to do this sort of research across multiple health systems involving multiple stakeholders, it's complicated, it's messy, and a lot of people's perspectives are really important. So there's a lot of work to try to make sure that the perspectives of patients, providers, the people in charge of data, and the health systems themselves are all taken into account in organizing and working together at Procornet. So patients and caregivers are integrated into all phases of Procornet-enabled research. The data are drawn from millions of electronic health records, and there's growing links to other sources of data. And in addition, our teams tend to be embedded or working closely with health system teams, so can help facilitate access to clinicians and other researchers across the country. So just to get you an idea of where the Procornet sites are, these are the 8 clinical research networks. Each one is shown by one of these big sort of teardrop shapes. And then each clinical research network is a network in itself. And then one of those networks, our local one, is the PATH network, which is shown here in the purple dots. And so we have 7 partners in the Mid-Atlantic and Midwest region. I'm going to come back to that in a second. Let's just talk a little bit about how Procornet governed. I think the governance structure is important because of this complicated structure, networks within networks. So there's site within a local CRN within a national network. But the bottom line is that the sites, the goal is that each site is an important partner that can actually contribute to national governance. Procornet is led by a national steering committee. There's a chair and a vice chair that are elected amongst the group. On the steering committee, there's representation from each CRN. So the PI and co-PI, which is typically a clinical researcher and an informatician, represent the network, the clinical research network on the steering committee. The 3 Procornet coordinating centers are represented. They do clinical research coordination, data coordination, and patient engagement coordination. There are 3 patient partners that are full voting members of the Procornet steering committee, and then there are PCORI representatives. We form work groups periodically to tackle key tasks. They include team members from across the network, and PATH team members have held national roles, and I just highlighted a couple of them here. One of them is Greg Merritt. He's a patient partner affiliated with the University of Michigan. He's one of our 3 national patient representatives on Procornet and has been very, very vocal in helping to shape Procornet policies. So we have a real strength. The PATH network is really proud to have helped make the connection to bring Greg to the Procornet steering committee. And then also I've recently served as vice chair of the national steering committee for Procornet. And I think that this highlighting these roles is important because the PATH team members with national roles also then report back to our local CRN, our local clinical research network, letting everybody know what's been going on in conversations at the Procornet level, and also integrating local concerns back into the national conversations. So just to move down a level to think about who is our local network, these are our regional partnerships. And so you can see that we have 7 health systems and they're affiliated academic partners. There are some very large health systems that do really large amounts of research. Some partners have larger or smaller levels of numbers of patients in the health system, but they bring important different perspectives. So we have some more rural sites such as Penn State and Geisinger. We have some more urban sites such as Temple and Hopkins. And those are also sites that tend to bring more racial and ethnic diversity to our group. If you look at the distribution of the patients in the PATH common data models, you can see, as expected, that they're particularly located in the Mid-Atlantic and Midwest regions, but probably reflecting the very large size of these health systems, that there are patients that remain affiliated with these health systems that can live all over the country. Now, this color scale is based on a log scale, so most of the patients obviously are very close to the local health systems, but they do travel from all over the country. So as we think about what does it mean to have access to electronic health record data across the nation in Procornet, a really important part of that is that our informatics team have put a lot of effort to try to make sure the data are usable, that they're not as messy as electronic health record data could be when you try to pull into research purposes. So we have a common data model, and it standardizes data into a single language, which is the goal is to try to make it much quicker and easier to use EHR data in research. The common data model is made up of a whole series of different tables. The ones that they call ready for research are shown here in green, and then the tables that are evolving and have had some use but are not used commonly and are still really sort of coming into their own are shown in the blue. The most common tables that are used tend to be some of the ones in green over here, such as diagnoses, medication orders, laboratory data, demographics, and procedures. Claims data are typically limited to a subset of sites that also have access to local health plan data. And death data, of course, tend to be relatively spotty because it relies on whatever death data is available in the EHR. And for many health systems, if the patient did not die in the hospital, the death data are not available. That just gives you an idea of the types of data that you can access through Procornet. I want to talk a little bit about what standardization is, because this is a very important part of what Procornet does in terms of preparing data for use in clinical research. So on the left here, you see 3 ways that 3 different health systems might perhaps code their race and ethnicity data. The first one uses Caucasian, African American, Asian, multiple race, or just leaves it blank. And the second one assigns each of a larger number of categories a number, and then site 3 has a sort of a similar number of categories as site 2, but they use text labels, but different text labels than the top site. In the common data model, they have defined a value set that says these are what the options are in Procornet, and every site then takes their data and tries to figure out, when they take their local data, they map it to this national standards, and as a result, the patients in site 1 that are labeled as Asian get labeled O2 equals Asian in the Procornet common data model. The patients labeled as 401 do the same, and those labeled as Asian American in site 3 all get the matching label in the common data model. As a result, when you pull data back out of the common data model, that step of data cleaning has already taken place. We have a standard curation process where on a regular schedule, the Procornet Coordinating Center sends queries to our sites and checks them for data completeness and a certain level of data quality. Tell you just a little bit about the query process. We can, of course, run queries within our individual CRNs, but if you wanted to do a national query, it's often done by using the Procornet Coordinating Center. You can see that the requester here is an investigator in green who has a research question. They come and they talk to the Procornet front door in the Coordinating Center with this robust intake process. This is what my needs are for the study. This is what I want to learn. The front door in the Coordinating Center data team can develop a query. The query is then sent out to the sites. The Procornet data are not stored in a single database in some region. Some networks have one data mart that for all of their sites. Other networks, and PATH is one of them, the data stays at home behind the local institution's firewalls. What happens is when the Coordinating Center query comes, the local teams get it, run it against their local data mart. It extracts only those data that are relevant to the study, typically leaving all the identifiers behind, and then returns those data to the Coordinating Center where they're compiled and then provided to the researcher. So it adds an extra level of security, where the hope is that we retain more sensitive data behind the firewalls and only release those data that are really needed for the study. So if you look within, we talked a little bit about the size of Procornet. So Procornet's very, very large. But even if you look within the regional network, our PATH network, there are across all of our common data models, there are over 14 million patients. And as you can see on this table here, there's some fairly remarkable diversity in terms of age, geography, and race and ethnicity. So it spans the entire lifespan, and there's about 13% African American, which of course varies by site. Other things, most people when they think about Procornet think about access to data, but it's important to keep in mind that PATH and Procornet can provide access to a variety of tools and other forms of expertise to support multi-site research. So there's the query infrastructure that we talked about. We also have cost models and can assist with how to budget for a multi-site study. We have existing data sharing agreements. So for example, there's a Procornet data sharing agreement. Every institution has already negotiated it. So if all you need is the identified data, you don't need to do any additional data sharing agreements. Even if you're working with 45 sites, you can use just that one data sharing agreement. It's already in place. All of the Procornet sites have experience with Smart IRB and project managers where time can be shared to help you implement a single IRB protocol using Smart IRB. And then we have some level of communication and dissemination support in terms of newsletters and social media both from the coordinating center and also to try to help get word out about important study findings to local patients and clinicians and other community members. PATH teams can also assist with tasks such as identifying collaborators for multi-site trials. So you might say, want to work with a whole bunch of sites. You have colleagues at a few of them, but not all of them. The PATH teams, because they're working within these health systems all the time, can help, and PATH and Procornet teams can help you identify collaborators, can help determine whether a study's processes will align with standard clinical care. Typically do that by working with our existing panel of clinical champions. We can help with recruitment of eligible patients for clinical trials, figuring out who's eligible based on their electronic health record data. We can help obtain preparatory to research data from the electronic health record, and also engage stakeholders as research partners. And I'm going to come back to that in a minute. Actually, I'm going to come back to that right now. So what is this? I know a lot of researchers have worked with stakeholders more and more, but still it's something that's relatively new in the clinical research front. Procornet and PATH teams are committed to supporting a wide array of research topics, but as we do that, we tend to champion patient-centered outcomes research. This is something that PCORI has really brought to the forefront. It's a movement that builds out of community-based participant research. And the idea that by having patients and other stakeholders be actual members of the clinical research teams, it can help get the right data, which is needed for patients and caregivers to make the really informed healthcare choices, and do a better job in assessing their healthcare options. And there's a few sort of possible questions that patients might ask of researchers as they think about getting involved in that process. In order to try to champion the idea of stakeholder engaged research, PATH has developed infrastructure specifically for this purpose in our Story Booth project. It's got three main goals. We try to amplify patient voices in order to inspire research questions that matter, as well as spreading hope among patients and caregivers. We do this by the generation of a fairly large now, about 950 stories told by patients, caregivers, or clinicians about what it's like to be sick, what it's like to try to maintain your health or to access the healthcare system. So we really work hard to try to let their perspectives be known and invite researchers to listen to them so that they can understand what are the important questions that need to be asked in order to make healthcare better. A side effect of that is that we have generated a rich repository or commons of qualitative data. So if there are any qualitative researchers out there who would like to hear patient perspectives, either as a qualitative research project, or it would be helpful for you to have a quote to use in a presentation or a research proposal, that this is meant to be a resource that's wide open to any academically affiliated clinical researchers, to try to help understand patient perspectives, and also to help build stakeholder engaged research teams. So basically we do team building or matchmaking, where if we have an interested a patient and a researcher who have shared interests, we can help make introductions and bring them together to form stakeholder engaged teams. So as I mentioned, we've got about 850 stories from individuals living in 29 states in the District of Columbia, and about 3/4 of the storytellers would like to hear about stakeholder engagement opportunities. So if you are interested in that, please let us know. I mentioned earlier that the PATH and Procornet teams can help support recruitment in multi-site research. And just so you can get an idea of the scope of that, this is a list of the trials that we have been involved in recruitment for. So, sometimes the PATH team is directly involved in recruitment. Sometimes there's another team that does it more so, and they just use our recruitment lists. But nonetheless, you can see that, over the last 5 or so years, we've been involved in recruiting about 15,000 patients. Now, I'll point out that, the University of Michigan column here looks a little sparse, but this is an artifact. This is because the University of Michigan was earlier part of a different clinical research network. And so because these are the numbers from PATH, that Michigan was not part of PATH for a number of these studies. Ohio State's in the same category there. So let me just quickly put it all together about what things that you might think about if you're considering working with Procornet or PATH for your research. That these networks let research be scaled appropriately for the question. You might want to work, just with the University of Michigan as a starting point, as a single site study. You might think, well, perhaps we're going to involve multiple health systems within a single site, or multiple sites within a single health system. You might want to do a regional study, perhaps engaging 2 or more path sites, or you might want to try to pull in health systems from across the country. It depends on your question and your funding availability. Secondly, the distributed data model is really important. It's standardized to national specifications, it's updated quarterly, and it lets analyses to be efficiently scaled and executed. The types of data you can get out of the common data model include preparatory research data, so just counts to try to make your grant proposal appear, so that the reviewers appear how feasible it is. You can do aggregate query projects where you don't pull any individual level data, just pull aggregate data across multiple sites. So you have maybe counts or scores or percentages. We could pull line level data for multi-site observational analyses of real world evidence, or help support multi-site pragmatic trials. In some of the ways we do that, as I've mentioned, is you might want to use EHR data to figure out who's likely to be eligible and reach out to them. You could help characterize the sample and also pull outcomes. In particular, people often use health service utilization data from the electronic health record. Oops, sorry, went ahead too far. And then finally, that we've got processes in place to try to help researchers be more efficient in undertaking their research, such as data use agreements, expertise with smart IRB, the opportunities for shared study staff, particularly as you get the study off the ground, so that as your HR processes take their time, perhaps you could use some local path or Procornet staff to help launch your IRB. Clinical champions, access to clinical champions to facilitate team building, and resources for engaging stakeholders. And then last, I have just a few use cases to try to make this a little bit more concrete. First, I wanted to show you an aggregate query project. So this is one where we don't pull any line level data. It's a project we recently did with industry funding on non-alcoholic steatohepatitis. This is an increasingly common problem. This project was led out of Pitt by Dr. Jay Bahari. All 7 path sites contributed data, and the dissemination team includes a patient partner. We examined adults that have NASH ICD-10 codes over 2 years. This was the original query. We compared it to patients who did not have NASH diagnoses on their charts. We excluded people who had other types of liver disease. And then we calculated FIB-4 scores that using data that are readily available in the electronic health record for many patients. And you're able to use those to figure out what's the probability of somebody having advanced fibrosis. Now, the original query results were really quite promising. And so a second query was deployed, which added some sites from across Procornet because the funder wanted to see more data on populations that had higher percentage of Hispanic patients. So we added a couple of sites from Texas and Florida and did an additional query. We've had 2 posters presented at the National Liver Meeting, and 2 manuscripts are currently underway. And then just sort of interesting, what we could find just from a simple aggregate query was that actually only about 0.07% of the patients in these 7 health systems, or 9 eventual health systems, were coded as having NASH, which is way lower than what's expected from the literature, suggesting that these problems are being under-recognized in clinical healthcare. There were a bunch of comorbidities that were much more common in the NASH cohort than in the non-NASH cohort. And then the people with NASH plus cirrhosis codes were much more likely than others to have advanced fibrosis, which you would expect. But that lots and lots of people did not have enough data to actually calculate the FIB-4 score. So there's some question about, potentially this non-invasive measure could be used to identify the people who have a misdiagnosis, but a lot of people are missing the data. But that's important if you're thinking about an implementation follow-up project. Among the patients who don't have a NASH diagnosis, there was a predicted, it appears that there's quite a lot of people who probably do have advanced fibrosis, and we're missing them. Okay, so another use case. This is a pragmatic trial, the Preventable Trial. This is ongoing. This is a very large NIH-funded study. The question is, can taking a commonly used heart medication, this is a statin medication, prevent dementia in adults over the age of 75. So one of the most feared outcomes among elderly adults. Procornet, they frame it as offered a one-stop shop for capturing 3 complementary sources of data. We're capturing Medicare data from some sites, EHR data and survey data that in a more efficient way than if you had done a traditionally designed research project. It's going to engage 20,000 patients who are over the ages of 75. There are 100 US sites, as well as between Procornet and VA sites. And it's using a pragmatic design with our EHR data, plus phone surveys, and all the consenting is, for most patients, is done via Zoom or phone, and the drug goes straight to their house, which is really important since it rolled out during the pandemic, and often, when we've been recruiting throughout the time when many clinical research sites were actually not open for business in person. So as they point out here, in response to COVID, they just added a telehealth visit, and we were able to keep on recruiting. And we've been able to support really relatively rapid enrollment, and have gotten some nice press about that. And then the third use case that I want to share is the Procornet Bariatric study. So this one has the question of, can Procornet be used to assess the effectiveness of 3 surgical procedures that are commonly used, but lack long-term comparative effectiveness research. So you may know that it's extremely difficult for people who become severely obese to lose enough weight to make a big difference on their cardiovascular outcomes. Bariatric surgery can have dramatic weight loss changes and has some dramatic impacts on lipids and blood pressure and diabetes. There is a new procedure that burst onto the scene in the early 2000s and has actually taken over most markets, but we don't really know, is it actually better than the older procedures or not? And so we looked at analysis of health records for 46,500 adults and 544 teenagers. This was actually the largest cohort of teenagers ever studied for bariatric surgery. And then we could look at the effects of diabetes on 10,000 adults with type 2 diabetes, and then whether or not more surgery was needed in about 35,000 adults. So just an important thing to point out, it might be obvious, but when you have such huge sample sizes, a really nice thing about it is that you can look at important subgroups and actually look at heterogeneous treatment effects. And that was something that we were able to do. It was really important because severe obesity is most common in Black populations, who are also people who tend to be more likely to have adverse health outcomes. And so the Procornet infrastructure let us look within specific subgroups, such as racial groups. So I'm not gonna dwell on the actual bariatric surgery outcomes, because I think this is more specialized than probably you're interested. But let me just to summarize by saying that there were some really important findings. They were published in very high impact journals, and that many of the health systems involved are looking at them closely and thinking about what, should this change anything in the way that we are delivering surgery. And then my last slide has to do with thinking about how does Procornet compare with other data aggregators. And that's something, of course, many of you are thinking about and we're asked about all the time. And so this slide compares a few of common networks out there, such as the ACT network, Trinetics, Optum, Odyssey, and Sentinel. If you look at feasibility queries, almost everybody does that. If you say which of these networks can identify patient populations for trial recruitment, again, almost all of these networks can do that. Coordinated data curation is less common. It's something that Procornet does do. And then the other place that Procornet really differentiates itself from other networks is the fact that we really try to foster easy connection with patients and providers. So with that, I'm going to just leave you with the 2 URLs that might be the most useful in terms of looking for follow-up information, and then go ahead and turn the floor over to Dave.
Okay, and since we've moved right along here, I think we'll take all of the questions at the end after Dave's presentation. So I think we can go straight to Dave now.
All right, can you hear me okay?
Yes.
Yes.
Good, thank you so much. Good afternoon. I'm going to be kind of moving on to the next stage of this. We've heard about Procornet at the national level, and we've heard about it at the regional level. And what I want to do now is kind of talk about how you develop the research site node at a local institution. I'll be using the University of Michigan's site node of PATH and Procornet as an example. So at the University of Michigan, Procornet is housed within MISHAR, which is the home of our CTSA award. And if you're not familiar with MISHAR, the CTSA is a very large NIH award that is given to support clinical and translational research, not just within the medical center, but across the campus in general. And MISHAR is the institute that does that and provides a number of services to faculty and clinical researchers in the conduct of clinical research. And one of the units within MISHAR is the Network-Based Research Unit. And that's where our Procornet node is housed. And as you see here, Procornet has the national network, as you just heard about, as well as the regional network, PATH. Other networks that are housed in here are the Trial Innovation Network. This is a required network if you are the recipient of a CTSA award. And it also has supporting networks, the ACT network, which is can assist with some of the informatics and cohort discovery. And then kind of analogous to the PATH network is the MARCH network, which is a regional version of the Trial Innovation Network that we also participate in. The third national network we are currently applying to become a part of, and this is PedsNet. This is a smaller national network, but as you might guess, it's focused on pediatric studies, and we hope to be joining PedsNet in the next year. So to give you an idea of what it takes to create a node of a network, this is how we're configured at the University of Michigan for our PATH network. And you can see there's a number of parts. There's an administrative core, there's a regulatory core, which has links over to other parts of the university in Michigan Medicine, to our regulatory and compliance, to our Office of Research and Sponsored Programs, and the medical IRB. We have participant engagement cores. We have financial cores. We have an informatics team that gets linked over to our research data warehouse and our doctor office, which is also the data office, and with HITS, which is our health informatics technology services. In addition, we have community engagement cores, and then we have an administrative core. So to give you an idea of what the work is like in terms of setting this up, it's really a number of relationships that have to get formed both within MISHAR, but also across other units on campus. So when we're setting this up, there's really two parts. There's the idea of network readiness, and these are the relationships that allow the network just to be in place. In Dr. Mataig's talk, you heard about the idea of having standing DUAs or having standing legal contracts that allow the networks to exist. So some of these relationships take place really outside the context of a study, but is basically just the network readiness and to be ready for studies to be received. And then, of course, the second part of these relationships are the conduct of specific studies that get laid onto the network. So our regulatory team is very much involved in terms of working both within MISHAR, but also with our regulatory folks for DUAs or for contracts, working with sponsored programs, working with our IRBs and our compliance offices to make sure that the studies are following regulations, that our data that might be involved are being properly handled and curated and distributed, because much of this work does leave the walls of Michigan Medicine, and we want to make sure we're doing that in a compliant way. The other team, in terms of participant recruitment, we have a unit within MISHAR that specializes in recruiting individuals for studies, but we also tend to work with crossing over to another network, the TIN network, in the trial innovation group. They have a research innovation center at Vanderbilt, and we work in collaboration with Vanderbilt quite a bit to make sure that our patient recruitment materials are of appropriate educational levels. Sometimes you would recruit differently in different regions of the country, that they're culturally appropriate, and so that you can have an opportunity to recruit individuals into studies from all over the country. And that unit is very active in terms of working with both the TIN network as well as our work with PATH. The financial unit, if you're an investigator and you're a clinical faculty member and you want to run a study, chances are you don't know a lot about the budgeting of a grant. Or if you do, you're more than happy to turn that over to the administrator in your department who handles that. For network-based studies, the budgeting for individual studies becomes even more complex because you're budgeting not only just for your single site, but if you're doing a multi-site study, you're having to come up with budgets that will be at 15 other sites or 50 other sites or however large your study is going to be. There's also two parts of the budget. There's the part that is you're handling within your department, but then there's also the part that's going to be handled by MISHAR and by NBRU. This may be the data or the informatics part. And so budgets are very complex, and many times the investigator just kind of throw their hands up and it's like, well, this is too difficult to engage in. Because of that, we have a specialized team that does try to help the investigator kind of navigate the waters of the budget, because network-based research is just more complex budget-wise than doing, say, a single site study or your typical R01. The informatics team is very active, and there's a number of people in the informatics team. And of course, they do have to interact because the data is not located in MISHAR. We have, at Michigan, the data is located in the research data warehouse, and we do go work through the data office to access that, and we work with the data office teams as well as the HITS team. And again, sometimes the data is mapped to the common data model. For other networks, it may be mapped to other models. So we work with multiple data models within NBRU. The community engagement team also works with the participant recruitment team, but the community engagement team also has a number of patients that work with us. And patients historically have worked in terms of recruitment, but we really envision patients having a much broader role than that. And when we work with patient partners, many times we'll engage our patient partners even at the idea stage of a study. It's not unusual for patient partners to perhaps even be a co-I of a study. Patients they help with the formation of the questions. They advise on how to design and how to ask questions and to study questions in the design. Once the study's in progress, the patients many times are involved in kind of monitoring the progress or answering questions or addressing issues that may come up during the conduct of the study. And they're also involved at the end in terms of dissemination. Procornet has been very good in terms of informing us how to better use patient partners. It's baked into the philosophy of Procornet, but we're using this not only in Procornet studies, but in more traditional NIH studies as well, because we believe that it really just makes for a better study when patients are involved at all stages of the investigation. And then finally, the administrative core. The administrative core plays a couple of roles. One role is kind of the orchestrator of all these other parts, and it can make sure that all these other parts are meeting their deadlines, that they have the resources they need to do their work. The administrative core really oversees the functioning of the entire unit and make sure that it's working at the level of MISHAR, but it also works at the level of the investigator, the faculty member who's conducting the study. Many times you're needing to match a investigator with a study that's coming from the network, or you may be helping an investigator launch their own study. And as you might guess, navigating these waters can be daunting. And so the administrative core provides kind of a shepherding service, if you will, to kind of help shepherd the investigator through all these various aspects of network-based research and to help kind of get them to where they need to be and make sure they have the resources available to them to not only just run a good clinical investigation, but to utilize the power of the network that exists. So let me show you an example of a couple of scenarios. There are a couple of ways that faculty members can get involved. One is the network initiated study. And this is when a study comes to us from another institution somewhere in Procornet. And we want to make sure we can find a match. We can find an investigator that might want to be part of that study. So we get the information from the network. The study is announced. And we do kind of a screening for feasibility, and we create a synopsis that's digestible for the investigators to take a look at, and we try to get as much information about the budget as possible. Many times there's an investigator-led webinar. We'll have additional information about the study. And so we try to make sure potential investigators are aware of that webinar and can be plugged into it so they can hear about the study. Then we try to make a match, and we check out, we make sure that the regulatory features are aligned with what Michigan Medicine is willing to do. We want to make sure that the informatics lift that's being required of that study is something that our informatics teams are able to handle and are able to comply with. And we got to make sure that the site budget is reasonable and feasible for the conduct of the study. If all those things match and we have an interested investigator, then we let the institution with the PI know that we have a U of M site and we want to participate in that. And then depending upon where that study is, that we can assist with the LOI or the subcontracting for the grant submission. The other scenario is when we have a U of M faculty member who wants to initiate a study. And so this might be an idea for a multi-site trial. So we will initially meet with that investigator. Within MISHAR, we have a research development core. that has clinical trialists, has statisticians, it has a number of folks that can help that investigator put together an initial idea. We also can work with the PATH network or with Procornet to float an initial idea past them, either through PATH's future research topics, or Procornet has what they call the front door, which is where you can present your ideas. The PATH also has an informatics consultation. If you're planning a study and you need to do some prep to research queries, for example, you want to identify which PATH sites maybe have a sufficient sample of the type of patients you're needing to see, the inclusion and exclusion criteria, they can help with those initial prep to research queries. We also will have our investigator deliver that investigator-led webinar, because if you're trying to advertise your study and have other sites join your site, that investigator will need to make that webinar presentation. And again, that can either be through PATH, through their future research topics, or through Procornet's front door, if you're going to go beyond PATH and have multiple regional networks participating in your study. Again, we then will help our Michigan site PI identify interested other sites. And again, the match has to involve regulatory, informatics, as well as site budgets, and to make sure that all those things are aligned. And then we assist our investigators in terms of getting LOIs submitted, as well as the grant submission. So that's just a kind of an overview of the process that we kind of shepherd our investigators through to make sure that their trials or their participation in the network goes as smoothly as possible. Let me give you an idea. We kind of break down a number of our studies into three parts. We kind of, you saw Dr. McTighe's breakdown of some studies. I'm going to show you some studies as well. Some data-only studies, as well as observational studies with recruitment, and then interventional studies. This study was a data-only study, and it was really one of the first examples it was a kind of a demonstration project out of Procornet. The original question was, are patients with hepatitis C who receive direct-acting antivirals at increased risk for adverse events? And this question was a valid clinical question. There was some suggestion, some anecdotal suggestion that they were at an increased risk. But by having this network in place, very quickly they were able to study over 33,000 patients in 3 different health systems to be able to answer that question just with the data on the electronic health record. And the outcome of that initial study was that they were not at increased risk, and so they were able to provide data to the FDA demonstrating the lack of any increased risk for this medical approach. The nice thing is this did not take years and years and years to answer this question. It was a relevant clinical question that was able to be answered using only data, and it was able to be accomplished in a relatively short period of time. An example of an observational study with recruitment, this is one that's happening here at the University of Michigan. It's called PRESERVE. This is one of the longest running studies that we've had with Procornet. One advantage of Procornet is the ability to study rare diseases, because usually single site studies have difficulty finding enough cases of a given rare disease. And so if you're able to combine a number of different sites, in this case, looking at preserving kidney function in children with chronic kidney disease, by combining 16 sites, you're able to get around 11,000 cases. And so this study is still ongoing. We don't have the results of this one yet. but it is an example of where you can study a rare disease by combining sites and using a combination of EHR data, as well as being able to recruit and look longitudinally. Another example of an observational study is the HERO registry. And this is an initiative that happened right as COVID was starting, where they wanted to create a registry of frontline healthcare workers. And this is an ongoing registry. It currently has around 55,000 frontline workers in it. And they've been able to send questionnaires to these folks repeatedly over the last couple of years to get answers, first of all, to be able to kind of track the health of frontline healthcare workers in the initial stages of COVID, and then to monitor things like whether frontline healthcare workers were receiving vaccines when they became available. They've been able to study things like job retention and burnout. And they've been able to take a look at long haul COVID as well in healthcare, in frontline healthcare workers. So this is an ongoing, it's kind of a live and living registry. They're starting to have some publications come out of this registry. There is an associated data dictionary that has a number of elements to that. It has kind of an overview and then baseline information, registry enrollment measures, for example. They have questions about social support. They have daily impact variables. They have some of the promise measures in there looking at general health. There's issues about mental health. They do look at burnout and look at a variety of symptoms and medication use that are able to be captured by the data dictionary. Anyone is able to access this, and right now there are a number of publications that have come out using this registry, but they're wanting more. They're wanting more investigation. This is a valuable registry, and surprisingly, there have not been a whole lot of investigators using this, perhaps because maybe it needs a little bit better advertising. But you can see some of the topics that have been published off of this. Again, taking a look at like racial differences and in the experience of outcomes of healthcare workers doing COVID-19, looking at employment characteristics, looking at facility characteristics, and looking at again, the topic of burnout. So again, a valuable resource, was developed by Procornet and is an ongoing resource that people can publish on. Finally, interventional studies. This is a large trial that Michigan took part in, the Adaptable Trial. Dr. Peter Fairhay was our PI here at Michigan. The research question was a pragmatic one. In patients with established pre-existing cardiovascular disease, is a strategy of 81 milligrams or 325 milligrams of aspirin better? So low dose versus high dose aspirin. This is a question people have in everyday use of their medications. The correct dose might present thousands of deaths from heart attacks or thousands of bleeds because aspirin is a blood thinner. So this is the design of the study. The primary endpoints were composite all-cause mortality, hospitalizations for myocardial infarction or hospitalization for stroke, and the primary safety endpoint was hospitalization for a major bleed. 40 sites were involved in this study. You can see where they were represented. And then here's the outcome. The primary effectiveness endpoint, all-cause death, hospitalization for MI or hospitalization for stroke. with the low dose aspirin looked like this. High dose aspirin looked like that. There was no difference. In the primary safety endpoint, you can see again, there was no difference between the two doses. And so the message to patients is that if you're on 81 milligrams now, staying on it rather than switching is probably the right move. If you're resuming aspirin, starting a lower dose is probably right due to better tolerability. But if you're already on 325 milligrams, staying on this dose may be okay, and associated with maybe some modest benefit. Recently, there's been some other COVID initiatives that have utilized the Procornet Common Data Model. The first I'm going to talk about is N3C. This is the National COVID Cohort Collaboration, or Collaborative. The idea here was to collect a huge database of individuals that had COVID so that it could be studied rapidly. And you can see it's really a national sample. They've taken EHR data from a number of institutions across the country. The model here is an interesting one in that you could digest data from a lot of different data models. So site 1, for example, may have Odyssey, site 2 may have a Procornet Common Data Model, site 3 may be having ACT, but it all gets digested into a cloud, an NIH data cloud, where it's converted to the Odyssey model. These are some key metrics from their dashboard. There's currently around 12 million people in here, 4.4 million with COVID. And this is their data domain. There's demographics, there's encounters and visits, diagnoses, conditions, procedures, labs, vitals, and medication. The way they have set this up is as a central database as opposed to a federated one, but they have 3 enclaves. There is one enclave that you can go into. You cannot download data on any of the enclaves, but you can go and you can work in the enclave itself, and they provide you with statistical tools for working on data in the safety of the enclave. The first enclave is a synthetic data set. It's actually not really the data, but it's slightly jiggered so that it's very similar to the real data set, but it's a synthetic data set. The other enclave is a de-identified data set. You do have to have training to have access to this enclave. And then finally, a limited data set is in the third enclave, which requires IRB approval to access. But again, all these enclaves are available. Currently, there's around 300 studies in progress on COVID using this centralized data source. And then finally, I'm going to talk about briefly Recover. This is the newest initiative, and Recover is also using Procornet data in some of its studies. And Recover is focusing on long haul COVID, or PASC, as it's referred to. This is their website, and the Recover initiative is structured like this. It is an NIH sponsored study. There's a Recover Executive Committee and a number of data centers, biorepositories, mobile health platforms. But you can see over on the side, there's a number of studies. There's 5 huge studies that are embedded in the Recover initiative. And these studies focus on an adult cohort that is longitudinal. There is a pediatric cohort, which again is longitudinal. There is a pregnancy study to study long haul COVID in the context of pregnancy. There is an autopsy cohort. to be able to look at symptomatology from a pathology perspective. And then there is an electronic health record cohort to be able to look at real world data. And the PATH network and other Procornet sites are participating in the EHR study. Real briefly, this kind of shows some of the breakdown of it. Because there are so many PATH cohorts or so many Procornet cohorts involved, there's like 40 of them. They've split them between 2 data coordinating centers. So 20 have CHOP as their primary data coordinating center site, and Cornell is the other. And even within PATH, some of the PATH sites are with Cornell and some are with CHOP. The University of Michigan is currently with CHOP, and we'll be contributing EHR data to this on PASC. So I'm going to stop there and see if there's any questions.
Thank you very much. I appreciate this. And I think we can now go forward and open the floor to people who want to ask questions directly. I see that Diane Harper has a number of questions for Kathleen. Diane, are you on, and can you unmute yourself and ask your questions directly?
I am unmuted. Can you hear me?
Yes, yes.
Yeah. Great. So I thank both presenters for very informative information. My questions in the Q&A really came as Kathleen was going through her talk, but I think that one of the things that I was interested in is, can you use Procornet to follow up people with abnormal test results who traditionally have not been good about coming back for follow-up, specifically on cancer screening, into care? If it's all de-identified data, how do you follow people? And can you only do that through the data sets? Because one of the problems we have is that people change insurance companies about every 3 years and change health systems. And so it's not like they're there forever. So how do you mix and match patients between health systems in order to get longitudinal follow-up, if you can do that? So I guess I'll start with that.
Kathleen?
So I could take the first try at that. And sorry, I may have missed a little bit in the middle because my computer froze. But I believe you're worried about patients changing health systems, and can you know when they do that and not double count? Is that correct?
It's more of understanding whether you can follow patients over time. So if I was looking at a 10-year longitudinal follow-up of patients for cancer screenings, how do I know where they got their next cancer screening if there isn't an internal way to connect patients between healthcare systems? Yeah.
So the solution that Procornet has contracted for is called the Datavant, and so Procornet has a contract for all of our sites have contracted with Datavant, and so we can have privacy preserving record linkage. And one of the things that they can do is to be able to tell when somebody appears in one health system and then that same patient appears in another health system. The way we do it is we have to send the data to the coordinating center, and then the coordinating center uses these hash tokens in order to tell when de-identified patients actually show up at other health systems.
Thank you.
Okay, related to that, I saw a question from Lillian Min, and asking the question about how complete the data is. Lillian, are you on?
Yes, I'm on. Yeah, my question is related to that. How complete is it? So just thinking about Michigan Medicine, when our patients go to Henry Ford or whatever, and seek their care elsewhere or are admitted emergently somewhere else, do we have that capability to identify them across healthcare systems and data sources? It sounds like, yes, the answer was there's an identifier in the central processing agency.
So yeah, we have the capability of using the DataVant hash token system to be able to link across systems. I mean, I think that the broader answer is that, you know, the data are as for any given health system, the data are as complete as they are in the electronic health record.
Yeah.
So it depends what you're looking at. For many questions, the EHR data alone are fine. But you know, if you want to make sure that you have complete health service utilization, a lot of times people will link claims data in. You know, which could be done with a data use agreement and traditional processes, or could be done using DataVant. There also are a subset of sites within Procornet that actually have the claims data. We have 3 sites now within PATH that have the local health plan data. So that's the, you know, complete utilization data for a subset of patients within the common data model.
I see. So 3 out of our
7. Mhm.
So Lillian, you also asked about pharmacy data.
Yeah, I mean, you had mentioned the medication order, so
Mhm.
the I guess you're answering about claims being available for only 3 sites. So would that be those 3 sites as well for the medication?
So
Part D?
our ordering data are much more complete than our fill data.
Yeah, obviously.
And so, yeah, so you would probably, if you wanted to do a study specifically on that, you would probably need to build in some sort of record linkage, either with claims or say working with SureScripts or some source of fill data.
How hard is it to get? Okay, maybe I think I know the answer. To link all the other sites with claims, I'd have to request a data use agreement and get. Yeah.
Yeah, so I mean, typically,
Right.
so first of all, most studies do not need to use all of Procornet. So typically people identify a subset of sites they want to work with. And some sites have claims data available. So it's a matter of sort of figuring out what sites have the claims data. Are those the sites that you want to work with? And then do you need to supplement that with additional data from you know, from whatever is the right source for your question? Does that help?
Great. And is that's on your website, which of the 3 sites have claims?
Hopefully it's UPMC Health Plan, Ohio State, and Geisinger.
Okay.
And they don't have it for everybody. They have it for the subset of people that have their, you know, it's like the UPMC Health Plan is a subset of.
Right, their own plan. Okay, thank you.
Okay, and then Tyler James asked a question about classification of populations, I believe. Tyler, are you on?
Yes, I'm here. Thank you so much. So I come from the University of Florida and I now work at the University of Michigan. And so a lot of my experience was with the One Florida processes. But so what I found was during my dissertation research, which was focused on deaf American Sign Language users, where language is an extremely relevant variable, is that the Procornet Common Data Model misclassifies American Sign Language in addition to other languages of lesser diffusion as an other language. And so even if a node in the Procornet or within one of the networks specifically codes an American Sign Language factor, it will become misclassified whenever it goes into the Procornet CDM. Do you know if there's been any movement into making sure that those languages of lesser diffusion are accurately available from the networks themselves?
I have not heard of any movement in that direction, but that's not to say that it couldn't happen. I mean, I think one thing to keep in mind is that we have just come out of a period of somewhat uncertainty where, you know, PCORI, they didn't know if they were going to get reauthorized. They've gotten reauthorized. We have just gotten reauthorized as well. And so, but for a few years, they really were doing not very much to build out the common data model. So I haven't heard anybody speaking to that point, but I think that if a compelling argument could be made, and in particular, if there was a you know, a study opportunity sitting there, I think it probably could be addressed, but it's not actually, I don't think it's on the radar right now.
Thank you.
And then finally, we have a question from, I hope I pronounced this correctly, Rumi Nusrat, regarding the studies. Rumi, you want to ask your question directly? Are you there? Okay.
Okay, I think
Oh,
there.
go on. Yes, go.
Well, this is the geek's question about precision. My background is in clinical trials that tend to be fairly precise. So the holy grail is somehow hoping that one day these type of systems will do what NIH and industry's trials can do, which is, are there any pilot studies to optimize agreement on disease definitions and outcomes? And I know this is not so easy. So you go after the low-lying fruit, which is mortality and hospitalization outcomes. So it's a two-part question. Precision, can you define diseases and outcomes precisely in pilot studies? And if you can't, how complete is the mortality and hospitalization data? Because that is often the only thing you can agree upon.
Yes, so I think probably I can give you a not entirely satisfactory answer to this. So one thing is the mortality data. The mortality data is not optimal. If you want to have really good mortality data, I would recommend that you link in NDI data. There are sites that get a Social Security feed or other reliable feed on death data. They typically address just mortality status, not cause of death. So there's a subset that have good data on that. I would say that Harold Lehman at Johns Hopkins, one of our collaborators there, is very interested in this type of question. And so I haven't actually seen a study addressing exactly your question about comorbidities and hospitalization, but that's the kind of thing that Harold is always talking about wanting to address. And the other thing to know about is that PCORI actually has method awards. And the last few years or the last few cycles, they have specifically released funding that where improving methods for data networks is one of the areas that they're looking for projects in. So I think if there is work in that area, I haven't seen too much of it. Dave, I don't know. Do you know of any work in that area?
Specifically, but just to your point though, the networks have been built. We usually add to them as studies evolve that need things added to them. Obviously, it takes money to add to the network. So I think the networks are getting better and better all the time as we do more and more studies that bring funding in to add data elements that can either make it broader or to make it more precise. And certainly, the area of looking at like patient-reported outcomes, for example, is one that is becoming a higher and higher priority, so that we can drill down more specifically on data that where PROs are being used.
Can I also address something that I spotted in the chat earlier? I want to just clarify a little bit, and that is that not all data in Procornet needs to be used in a de-identified fashion. It's just that the Procornet data sharing agreement addresses only de-identified data. If you need a limited data set, or if you're or other sorts of data, you just need to implement a supplemental data use agreement. And also a question we get often is, does the funding need to come from PCORI to use Procornet? And that's not true. We've had studies with NIH funding, ARC funding, American Heart Association funding, industry funding. The funders can be from diverse sources.
And I have a question here from Josh regarding sort of the future of funding and so forth. Josh, you want to ask directly?
I'm muted, I will.
Yeah, we can hear you.
Hi, the camera's on. Yeah, I just wanted to ask about, you mentioned the reauthorization. I guess I wanted to get curious, in a minute or two, if you could talk about the People-Centered Research Foundation and how that transitioned to, and then I guess out from the People-Centered Research Foundation happened, and what the future horizons look like. Thank you.
Yeah, that's a big question for a minute. No, so
I don't think it's too much time. Thank you.
Yeah, so essentially, they had at some point envisioned, not knowing whether PCORI would be sticking around. There had been a non-for-profit form that was going to administer Procornet. PCORI got reauthorized, and so eventually the PCRF was disbanded, and now we are back directly under PCORI funding. Does that help?
Absolutely. I'm sorry, my question box keeps popping over the mute button, but yes, that's helpful. So PCRF is no more. It's back to PCORI, sort of the way it was, I think 4 or 5 years ago or whatever.
Right. They you know, if PCORI had been disbanded, they didn't want Procornet to also disband. So that was, PCRF was, you know, helped avoid that. But the really good news is that PCORI is staying around.
Beautiful.
And Josh, I think you were also curious about research in the primary care space.
Yeah, absolutely. I was curious, do you have a sense of how much research now is happening in primary care? I remember a few years ago, that was one of the issues, that there wasn't much research happening in primary care. And has that changed at all since COVID? And is that in terms of the kinds of research being done on the networks?
So not a lot of research has been focused specifically on primary care, but I will say that the PATH network is one where we actually have a number of our site PIs are primary care leaders, and it's an area that our teams have specific interest in. And I think that it's a great place for opportunity in researching in Procornet. We've got a lot of colleagues, we've got a lot of connections in that area. There are many, many questions that could be answered. So I would encourage you to, if you have a study that you think might work, reach out, and we'd be happy to talk about it.
Dave, any additions to that?
I'm sorry, say that again.
Are there any additions to that with regard to primary care research?
No, that's true. And at Michigan, we are starting to have more and more interest from folks who are in the primary care arena. MISHAR is starting to expand its network out into other more remote areas of Michigan. And we hope that we'll be able to capture some of that, and hopefully some of that will be in primary care as well.
Okay. Well, I do not see more questions in the Q&A box, but we have a few minutes left here. If anybody wants to raise a question, please do that.
Looks like there was a question about the storytelling, about whether it was addressing inpatient experiences or just chronic conditions. And storytelling project is wide open. We want to hear the patient's perspective. So we let them tell the story they want to tell.
Okay.
Is that like moth NPR storytelling time?
It was inspired by StoryCorps, and actually we had a StoryCorps came and ran a workshop for us to try to that. So we've used a lot of their approaches in setting it up.
Nice.
Okay, well, I think we're about at the end of our time. I think everybody would agree that this has been an extraordinary view into how you actually can use network-based research and participate in it, and provides a great visibility of what it takes to be successful in this area, and how you can reach out for support to undertake these activities. So I want to thank both Kathleen and David for their presentations, and I want to thank all of you for the good questions. And we'll look forward to seeing you again at a future session. Thank you so much.